From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Welcome to this JAMA Clinical Reviews podcast. I am David Simel, Associate Editor for JAMA. In this podcast, we will be discussing paroxysmal supraventricular tachycardia. To address this topic, we are pleased to be joined by Dr. Paul Zei, who is an Associate Professor of Medicine at Harvard University and Director of their Comprehensive Atrial Fibrillation Program. Dr. Zei is one of the authors of the Review on Diagnosis and Management of Paroxysmal Supraventricular Tachycardia that appears in the February 20th, 2024 issue of JAMA. Dr. Zei, thank you for joining us today.
Thank you, Dr. Simel. It's a pleasure to be here.
Well, let's get right into it. By its name, paroxysmal supraventricular tachycardia, which we're going to refer to as PSVT, occurs suddenly. If I'm in the clinic and a patient has been experiencing PSVT at home, how would they explain their episodes to me?
It's varied. So some patients are symptomatic and some are not symptomatic. And those who are symptomatic typically describe episodes just like the moniker, meaning that they sense some sort of a symptom of tachycardia, whether it's palpitations in the chest or rapid pulse, or sometimes palpitations even up in the neck or the throat. And paroxysmal, meaning that episodes start suddenly and stop suddenly typically.
Are their palpitations uncomfortable to them?
They certainly can be. So you might feel anything from nothing else associated with the rapid heartbeat to feeling a sensation of breathlessness or shortness of breath, a sensation of lightheadedness, perhaps even a sensation of just feeling generally off or anxious. Some patients typically have episodes that can last anywhere from seconds to minutes. That's quite common. But then there are others where they will last quite a long time. I've had patients who've come to me describing episodes that have lasted an entire day, and they somehow are able to just continue on doing what they do and try to ignore the episode, or perhaps they eventually will seek medical attention for that prolonged type of an episode.
As opposed to sinus tachycardia, what is happening to electrical conduction during PSVT?
During sinus tachycardia, an external or extraneous input or etiology or cause leads to increased adrenergic tone or perhaps decreased vagal tone, which then causes that sinus node to intrinsically fire in an automatic way more rapidly. And that's a normal physiologic response typically to, again, an external source such as anxiety, pain, blood loss and hypovolemia, or other similar types of adrenergic stimulants, as opposed to SVT, which is an abnormal rhythm that originates typically from somewhere that's not the sinus node. And there can, of course, be various locations in the heart that can be the source of this, what we call the electrical circuit for an SVT. And by just the moniker and definition, SVT meaning supraventricular tachycardia, we typically define as above the ventricle. So that can include the atria or the AV nodal tissues.
How do you confirm the diagnosis?
Like almost every arrhythmia that we evaluate, the confirmatory diagnostic tool is some form of an ECG. So an ECG, whether it's a full 12-lead ECG or a single lead event monitor or a long-term ambulatory monitor, or nowadays many patients, as you may know, have personal ECG recording devices. And by analysis of the ECG, we can typically have high confidence whether or not it's an SVT or some other sort of an arrhythmia.
Tell me a little bit more about wearable devices, because I do have a lot of patients that are asking about them.
A wearable device, typically, the way I think about it, is a device that's essentially a consumer product. It may or may not have gone through a regulatory pathway to achieve a clinical indication for use, but either way, a patient is able to own the device for themselves and then use it either all the time or on an as-needed basis to record an ECG. And that, again, can be either through a wearable watch, typically, or sometimes a strap around the chest, or sometimes a separate device that they'll carry with essentially electrodes that you can place some part of the body, usually the fingers on, and then that will record a electrical signal. And it turns out this has been evaluated in various clinical studies, various types of wearable devices. And overall, the sensitivity and specificity of these devices is actually reasonably good, because if you are able to record a reasonable quality, higher fidelity ECG recording, the diagnosis typically can be easily made, especially when a specialist or even a generalist who has ECG reading training takes a look at those tracings from the ECGs. Now, what's I think still a little bit of a black box and undetermined is when these devices utilize algorithms built into the software to try to analyze those rhythms. My take on it is that still remains to be seen how validated those types of algorithms truly are.
When a clinician decides to order an event monitor, could you give some guidelines for the type of event monitor that they should request?
Absolutely. I think that's a great question. There are devices that are able to be worn continuously for longer and longer periods. So more maybe classically or traditionally, if you want to put it, is a 24 or 48-hour Holter monitor. So you wear electrodes connected to a recording device that will record your ECG for, again, anywhere from 24 to 48 hours continuously. Now, more contemporary devices sort of miniaturize that whole system to where rather than having electrodes connected through a wire to a recording device, which is often a sort of a bulky box, there are various devices available now that are all contained into an adhesive, smaller unit, typically, in the range of about maybe 1.5 by 3 or so inches wide, and often called a patch monitor that then just is placed on the skin, sits there again for as long as you need to or want to record. And then there are other longer term monitors that you use as needed. So you carry it around with you. And when a patient feels symptoms, they will bring out the device and use the recommended sort of strategy to record an ECG, whether it's on their chest or on their fingers or something like that. There are also implantable types of monitors, which have the advantage that being implanted, they're inside the patient and will always be available to record, and often record by a looping mechanism, meaning that they'll continuously record. So that's sort of an overview of the available types of devices. And when you're trying to decide what type of device, I always say that you want to match the cadence of the patient's arrhythmia symptoms as well as the duration of the patient's symptoms to the type of device, meaning that if a patient has relatively very rare episodes, let's say an episode occurs every few months of symptoms, it really doesn't make much sense to have them wear a 24-hour monitor, which will almost certainly not capture an episode. On the other hand, having a patient wear a device for a month when they have daily or several episodes a day, that's probably unnecessary, but you certainly won't miss anything. If a patient has episodes that occur and are prolonged and symptomatic, the patient can have the type of device that they just carry around with them and only record as needed, because they'll be able to prompt themselves to record when they have symptoms. So that type of a monitor certainly won't work as well if a patient is relatively asymptomatic, and also if they actually have something like syncope, because if they've lost consciousness, certainly they won't be able to have the wherewithal to find the device and record.
Well, that sets us up to discuss a common clinical scenario. Let's say we have a patient who has known PSVT and they're either at home experiencing an episode or maybe even in your office experiencing an episode, and they're hemodynamically stable. What are the first steps the patient or I can do to help stop the paroxysm?
Yeah, so what you're describing, again, in a patient who we have a confirmed diagnosis of PSVT, and we know that they're, as you said, stable, then with those two caveats, patients often can have successful termination of the episodes on their own, usually first with what we describe as vagal maneuvers, meaning maneuvers that the patient can initiate for themselves that then essentially activate the vagal limb of the sympathetic or the autonomic system. Most of these SVTs are what we call AV nodal dependent, so that they rely on electrical signals passing in part of that circuit through the AV node. So if you can slow down the AV node, you have a chance of terminating the tachycardia. Now, if vagal maneuvers are not effective at initial go, then oftentimes a patient can be prescribed safely a regimen of a medication that they take as needed.
What pills are you talking about, and how long does it actually take to absorb and abort an episode?
The most common two types of medicines utilized are either beta blockers or calcium channel blockers, both of which will have effect on the AV node. And most immediate release formulations of both of those classes of medicines probably reach an effective blood level within the range of, I'd say, 20, 30 minutes and won't reach a blood level peak for actually a couple of hours. So I would counsel the patient that they would expect at best an effect perhaps in that 20, 30-minute range.
For the person who is having slightly more SVT than is acceptable to them for the pill in the pocket approach, is there a daily medication approach that will decrease the number of episodes?
Yes, certainly. Taking daily medication is a well-established strategy to manage SVTs in many symptomatic patients. So most commonly, we utilize either beta blockers or calcium channel blockers. Most patients with SVT tend to be a little bit younger and as a result can be more active physically. And as a result, some of the side effects that are typically encountered with beta blockers and calcium channel blockers are often quite impactful on quality of life for some of these patients, especially beta blockers, which can limit peak heart rate during exercise or cause other side effects such as fatigue in general. But if tolerated, they can be reasonably effective for the patient.
So let's say we have a patient in the emergency room who is tolerating it, their episode of supraventricular tachycardia, but you're a little worried about them. Can you talk about the use of adenosine in that situation?
Yeah, so adenosine, which is a very commonly utilized medicine for SVT, as you may all know, is by definition an intravenously administered medication. And if a patient is hemodynamically stable, it can be used. The mechanism of action for SVTs, at least, will have a very transient effect of AV nodal blockade. And so it's typically administered. Many practices will administer a 6 milligram dosage. Those of us in electrophysiology typically will sort of jump right to a 12 milligram administration. And because it's dissipated quite quickly and broken down quite quickly in the bloodstream, we typically will want to also follow it with a relatively rapid saline flush to make sure that that bolus sort of stays essentially rapidly moving towards the heart where it needs to have its mechanism of action. And then that transient AV nodal blockade, just like we discussed for pill in the pocket AV nodal agents or vagal agents, and then SVT that is essentially mechanistically dependent on the AV node, it will slow down AV nodal conduction, in fact, potentially block it fully, and then allow termination of the SVT. Now, if I could just have a quick diversion, is that some SVTs, what we call SVTs, where we can't quite see on ECG or determine confidently the mechanism on ECG, may turn out to be either an atrial tachycardia, which is not AV nodal dependent, or even an atrial flutter, which is reentry within the atrium that is also not AV nodal dependent. Adenosine still can be helpful from a diagnostic perspective in that when you have that transient block of the AV node, then it essentially reveals that ongoing atrial activity without ventricular conduction. So it makes crystal clear in many instances, what's happening mechanistically. Now, a couple of other things to mention about adenosine is that patients typically describe to us that it really doesn't feel good to them. They describe things like a sense of impending doom, or they may get pre-syncopal or have a flush sensation. So it's not very comfortable with those few seconds where the adenosine's having its effect. And then secondly, because it can have some bronchospastic effect, it should be used with caution in patients with any sort of reactive airways disease.
Now, at some point of frequency of episodes, or for certain patients, you just want to fix the problem. Can you describe what is done during an ablation procedure?
Yes, absolutely. Catheter ablation is thought to be essentially a first-line therapy for many patients with symptomatic, frequent episodes of PSVT, and it's commonly performed around this country and around the world, especially for SVT. Catheter ablation has been a procedure performed now for several decades. It's likely to essentially cure an SVT with a high degree of likelihood. Studies have demonstrated anywhere from the low to mid to upper 90% success rate over long-term follow-up with a relatively low risk of serious complications. So what's happening is that we are treating that source of the arrhythmia essentially by disrupting the electrical circuit permanently with thermal energy. So to do that, we enter into the heart with catheters, typically through the femoral veins. The patient is typically also relatively awake, lightly sedated because adrenergic tone can affect what we call the inducibility of the arrhythmia. And then with catheters inside the heart, we can then purposefully induce the arrhythmia, usually with electrical pulse stimulation. Once we've confirmed both the mechanism and the precise location of the targeted abnormal limb of the circuit, then a specialized catheter is moved into position at that abnormal site. And most commonly, radio frequency energy, which then heats the myocardial tissues, causes eventually disruption of that circuit and then permanent fibrosis, which then leaves that area unable to promote or create SVT anymore. And that's more or less how an SVT ablation works. They typically, for a patient, take about, I'd say on average, 1.5 hours plus or minus. Most of them are often same-day procedures. Aside from typical vascular and cardiac complications, which are quite unlikely, depending on the location of the abnormal circuit that's targeted, there are varying degrees of risk of injuring. Typically, we worry most about is the critical parts of the AV node, which can, if injured, lead to AV block that's iatrogenic and may, in worst case, end up requiring a pacemaker implantation. So that is a known complication, although relatively infrequent.
Is there anything else you would like our listeners to know about PSVT?
Yes. So PSVTs can happen across the spectrum of the patient population that we encounter. And there are specialized patient populations where certain other factors need to be accounted for. First, I would like to just mention is the pediatric population. So as an adult electrophysiologist, I personally don't take care of pediatric patients, but there are certainly pediatric specialists that can provide expertise in managing these patients. Like most things with kids, dosing of medications needs to be tailored to patient size. And then in particular, when we're talking about catheter ablation, pediatric electrophysiologists, I would say the bulk of their procedures that they perform are in fact SVT ablations because SVTs are so common relative to other arrhythmias in children. So they have usually an expert pediatric electrophysiologist will have excellent experience in dealing with this issue of PSVT. The second important category to mention is the pregnant population. So oftentimes a patient who has a known diagnosis of SVT can have worsening episodes, meaning more frequent or more symptomatic or longer lasting episodes during pregnancy, thought to be part of the pregnancy-related physiology with high blood flow state, higher adrenergic tone and such. And so at least preemptively in a patient who's known to have SVT, it would, I think, be worthwhile to at least have a conversation with that patient about awareness of frequency of episodes. And like with other medical entities that are treated during pregnancy, we have to always keep in mind potential interactions and contraindications with whatever therapy we're considering, whether it's medication or less likely ablation during pregnancy because of risk of harm to the fetus. And in that scenario, oftentimes a maternal fetal specialist that has experience dealing with these kinds of issues would be extremely helpful in that scenario. The last, I think, important population just to mention is the athletic patient. So a patient who's either a professional or at least a high-level recreational athlete. And that bears special mention because oftentimes, especially if episodes tend to be triggered by these higher adrenergic tone states, such as exercise, these episodes can be quite bothersome, and especially in the professional athlete, in fact, disruptive to their professional career. So there often are higher stakes at getting the symptoms under better control. And so again, a specialist like an electrophysiologist often can help manage this. And oftentimes there's a relatively lower threshold to consider or offer catheter ablation as a means to also avoid these medicines, which may also in the end impact the patient's athletic performance.
Dr. Zei, thank you for joining us today to talk about paroxysmal supraventricular tachycardia. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMA Network Audio, all one word, .com. Thanks for listening.